Greetings and welcome to EHA Unplugged, the official podcast channel of the European Hematology Association, EHA.
Hello, I am Isabel Olivera, a medical writer at the European Hematology Association, EHA. Welcome to this podcast on how to improve the management of thrombosis and thromboembolism risk in pregnant women. I have the pleasure to have here with me today Professor Saskia Middeldorp. Welcome, Professor Middeldorp. Can you please introduce yourself?
Thank you very much for having me. It's really a pleasure to be here. My name is Saskia Middeldorp and I'm an internist trained in vascular medicine and a thrombosis and hemostasis specialist. I am head of the Department of Internal Medicine in Nijmegen, the Radboud University Medical Center in the Netherlands. And much of the work that I have done over the years have been done while I was leading the thrombosis research in Amsterdam.
Thank you for being with us today. We are going to discuss the medical and ethical challenges of conducting randomized clinical trials in pregnant women to prevent VTE. Can you please explain briefly what is VTE?
Yes, so venous thrombosis and pulmonary embolism are collectively called venous thromboembolism, or VTE. And it clearly is a quite prevalent disease, about 2 to 3 per 1,000 inhabitants per year, and it's strongly age-related, meaning that it is more prevalent at an older age. But what we forget is that it's also occurring a lot in younger patients, and particularly in younger women, because hormones, so that is pregnancy, the state of pregnancy, but also obviously the oral contraceptive pill or assisted reproductive technology regimens are strong risk factors for VTE. And it causes a lot of morbidity. And also it's the number 1 or maybe 2 of mortality in pregnant women. So I think it is an understudied topic if we just focus on the young women.
So pregnant women have a higher risk than the general population of developing VTE?
So they have an acquired or transient risk factor for VTE, but it's quite a strong risk factor, and many women become pregnant somewhere in their lives. And still the risk is per pregnancy or per pregnant woman is quite low. So we don't really consider it as a huge problem. I think we is the society. But if you zoom in on that it's the number 1 or 2 cause of death in Western countries, pulmonary embolism in young women who are pregnant or postpartum. I mean, imagine if that would be you, or if it would be your wife or your sister or your daughter or your mother, losing her because she's pregnant or giving birth is really inconceivably terrible. And even if it's not death, when it's DVT, so deep vein thrombosis, pregnant women very often have the thrombosis very high up, so in the iliac vein, very proximal. And that means that let's say the lifelong consequences of post-thrombotic syndrome can be very, very severe in these women. So the impact of VTE in pregnant women is enormous.
So this means that there is a need for prophylaxis, and the possibility would be, in theory, aspirin or low molecular weight heparin treatment. What is your view on this?
Yeah, so I think it's really a challenge to find the women who have a high enough risk to have thrombosis or pulmonary embolism related to pregnancy. That is number 1. So we have to pinpoint on the high-risk women. Because in pregnancy, low molecular weight heparin clearly is a burden. It means 10 months of needles if you want to provide prophylaxis during pregnancy and postpartum for 6 weeks. Guidelines are quite clear about this, even though the evidence is not enormous. We know that, for instance, women with a history of venous thromboembolism, that all of those women need postpartum prophylaxis for 6 weeks, and most women also need antepartum, so the entire pregnancy prophylaxis. And basically, from, let's say, the more effective treatments, low molecular weight heparin is the preferred option. Aspirin is an interesting option because for lower risk women, let's say the threshold to give yourself subcutaneous injections for such a long time is a big barrier. But first, so aspirin is interesting for, let's say, a bigger population or for primary prevention in high-risk women. But it will, we know that from non-pregnant population, it will not be as effective on an individual level. So my research has really focused on low molecular weight heparin in women with a history of venous thromboembolism.
So if you have a high risk of developing VTE and you're pregnant, will you recommend to give this woman a treatment of low molecular heparin for the whole pregnancy?
Yeah, the threshold for, let's say, antepartum prophylaxis depends on who you ask this. But we think that, so let's say a panel of the ASH guidelines, for instance, where I was also a member of, we have a threshold of about 3% of risk to justify 8 months of antepartum prophylaxis. There is no rationale, for instance, to start later in pregnancy, which is very often asked, because we know that the risk is increased from the immediate beginning of pregnancy. Now, for postpartum prophylaxis, where it is only 6 weeks of needles, the threshold is about 1%. If you compare this to non-pregnant individuals, let's say the medical patients that we treat with low molecular weight heparin in hospital, that risk is much lower. So for some reason, because of the duration and the burden, we actually already accept a higher risk of thrombosis in our practices.
Well, clearly, conducting clinical trials in pregnant women is something ethically challenging because of the risk to the unborn child. So what are these guidelines based on at the moment?
So I think the thresholds of accepted risk to justify prophylaxis with a burdensome low molecular weight heparin for a long time are based on observational studies. And I think this is fine. We need observational studies to see how big the risk is. But there are hardly any randomized controlled trials in pregnant women in this field. And I think that is unethical. So all the recommendations, for instance, on the optimal dose of low molecular weight heparin, which was the topic of the high-low study, is based on other populations, which is really strange. In my view, if we know the safety of low molecular weight heparin, because that is prescribed in clinical practice globally for such a long time, and we have large observational studies that already know that low molecular weight heparin is safe to the fetus, then I think it is rather unethical that clinicians like myself are basically treating these women with prophylactic doses that have never been studied in this population. So if someone tells me it's unethical to perform a randomized controlled clinical trial in women who are pregnant, then I say I think it's unethical not to do that, because now we are basically experimenting in clinical practice without a good study protocol and without an ethical committee who is considering risks and benefits.
But you have managed to navigate the difficulties of conducting randomized controlled clinical trials in pregnant women. Can you tell us what you see as the main challenges to do this?
So I think main challenges are the urgency that let's say the unmet need that is not always appreciated by funding bodies. So it's quite challenging to get funding. We do know, obviously, that pharmaceutical companies can be very good funding opportunities, but this is all a registered and marketed medication, and we know that there is hesitation also in pharmaceutical companies to sponsor these trials because of let's say issues with liability or perceived liability. So that is one barrier. The other, I think the women, for instance, particularly the women at high risk, so the women that I have studied, the women who have a history already of VTE and now become pregnant. We have shown in the high-low study, for instance, that these women are very much willing to enter these studies, to participate in these studies. So for the high-low study, we actually also had women who participated multiple times during the study. So we know that the women are not the barrier. And then we have, of course, the relative rarity per, let's say, clinician or per center. So what you need is large trials, large clinical trials with multiple centers and very often multinational centers. And there one of the barriers, obviously, is also, again, contracts between hospitals, money, basically that. So the trials that I have conducted also in the era of recurrent miscarriage and thrombophilia. You need a lot of persistence and patience, but it can be done.
Can you tell us more about women with recurrent miscarriage and thrombophilia?
That's the ALIVE-2 study. This is also a much needed area. A lot of women with recurrent miscarriage get thrombophilia testing, and if positive, they get low molecular weight heparin. And in our randomized trial, the ALIVE-2 study, also published in The Lancet in 2023, we showed that this is not effective at all. And therefore, I would like my colleagues to refrain from thrombophilia testing in women with recurrent miscarriage and not to provide low molecular weight heparin with the aim to increase the live birth. So it's high-low, it's ALIVE-2, and there is more to come, and others are also now, having showcased that we can do this, are fortunately studying pregnant women in the future. And I would like to inspire the audience. If you're interested, just drop me an email and I can connect you to others.
So how do you convince people that this is something that you should and that can be done?
So I think they're in the network that we are in, so the national VTE networks that are existing in multiple countries, but also we have an international network of national networks. It's called Invent VTE. And that is an academic network where we try to, let's say, that facilitates the networking that is needed to get everyone together. And there are a lot of let's say, friends, scientific friends, colleagues in those networks who are willing to participate in these trials, even though there is few money. And for instance, for high-low, the French network acquired French money. For the ALIVE-2 study, the UK colleagues acquired money. And I should not forget that the Irish colleagues got also money for high-low, Irish money. So it's more like it's a very different way of funding trials. And it can be done on the fly. It's not flying, it's going very slowly. But we have to get rid of that idea that you need to study this trial and finish it in 3 years, otherwise you have failed. If we would have gone that path, then none of these trials would have succeeded. So you need a lot of time, a lot of persistence, and a lot of great friends and colleagues who are willing to also, let's say, look for additional funding in their own countries. And that is how we managed to complete these trials.
So to finish in a more personal note, what inspired you to specialize in thrombosis and thrombophilia in pregnant women?
Yeah, so I think, to be quite honest, thrombosis just was an opportunity. I just got in touch with very good clinical colleagues, my mentor. But as soon as you start studying it, it becomes interesting because you know more, you get to know more, and you get to know better what you don't know. And that is interesting. But the young women, to be quite honest, is a personal drive that just occurred to me from the office, from my clinics, because I was just frustrated that for these young women in whom the impact of VTE is so enormous that we basically don't know what to do, whereas we know what to do in many other vascular diseases. So that's sort of, if you don't know the answer, if every time you get a consultation, should we do this or should we do that? And then you have to figure out, how can I help solve the clinical question? But I must say, I'm not only interested in young women. So, I mean, special populations as a whole, like cancer-associated thrombosis or optimal anticoagulant treatment in patients with parenteral home nutrition. It's more the vulnerable population that others seem to think about, this is too difficult to tackle. That is what gets me going.
Well, thank you very much, Professor Middeldorp, for sharing your time and expertise with us. And thank you to all of you for listening.